Hello, everyone. I would like to thank the organizers for giving me this opportunity to speak at this symposium. I have no disclosures that are relevant to this talk. Listed are the objectives I aim to cover in today's talk, basically to describe MIS-C as a hyperinflammatory state temporally associated with SARS-CoV-2, recognize the distinct immune dysregulation in MIS-C, discuss the lessons learned from cytokine profiling, discuss the existing clinical guidelines for immunomodulation in MIS-C, and describe the immunomodulation algorithm that we use at Children's National. Before we start talking about MIS-C, it's important to understand that the terminology to define MIS-C is different based on the region. The UK has a slightly different definition from that from CDC and that from the WHO. In the UK, it is called the PIMS-TS, that stands for Pediatric Inflammatory Multisystem Syndrome, temporally associated with SARS-CoV-2. MIS-C is a rare condition affecting 2 in 200,000 individuals less than 21 years of age. This is a pictorial diagram that the CDC came out with, which is current as of May 3rd. As you can see, the distribution of MIS-C is not uniform. The underpinning of the clinical manifestations of MIS-C is hyperinflammation, with a subset of patients presenting with features of Kawasaki disease, another subset presenting with cardiovascular shock, and patients also presenting with GI or CNS manifestations. In essence, patients may have several of these overlapping symptoms. With this background, let's talk about cytokine profiling in this condition. Dr. Levin, in his New England Journal editorial, eloquently described our understanding of MIS-C as a blind man trying to describe an elephant. The group at CHOP was able to demonstrate that the inflammation in MIS-C is distinct from that seen in severe COVID-19 infection in children. In panel A, what they did was they generated a heat map of the most differentially expressed cytokines, specifically the interferon gamma, IL-6, IL-8, IL-10, and TNF-alpha. And they were able to demonstrate they were different signatures in MIS-C patients compared to severe COVID infections. They then tried to use the cytokine profile as a 5-dimensional vector. They could not find a difference between severe COVID infection and MIS-C. However, the sum of IL-10 and TNF-alpha was able to differentiate between severe COVID infection and MIS-C in their cohort. There is a distinction in the plasma proteins between MIS-C and Kawasaki disease, as is described in this principal component analysis, where the gray dots represent the MIS-C patients and the pink dots represent the Kawasaki patients. The proteins that were notably different were IL-6, IL-17A, and CXCL10, with IL-17A, with most of these being increased in Kawasaki patients. Serum cytokine levels in MIS-C patients show an elevation of IL-6 and IL-10. There is also elevation of soluble IL-2 receptor, IL-18 and CXCL9, although they, in comparison to a historic macrophage activation syndrome cohort, the response was less robust. This heat map depicts the multiplex cytokine analysis in patients with MIS-C who were compared to healthy people with COVID infection, both in the pediatric age group and in the adult age group. And by unsupervised hierarchical clustering, they noticed that the MIS-C patients cluster together. There is a very high signal for IL-6. And as you can see in the principal component analysis here, the solid yellow circles represented by MIS-C separate out nicely, and during convalescence, they shift their cluster. Further, the MIS-C circulating immune profile was marked by cytokines and chemokines that recruit NK cells and T cells from the circulation and modulate their functions, such as CCL9, CXCL10, and CDCP1. Additionally, mediators of neutrophil and monocyte chemotaxis and differentiation and activity were also elevated in MIS-C patients. It is also interesting to note that there is a stark upregulation of PD-L1, which is an anti-inflammatory cytokine, reflecting a host-driven compensatory response to the inflammation. Cytokines potentiating mucosal immunity were also prominently elevated in MIS-C patients, specifically those related to T-cell helper functions such as IL-17A and mucosal chemotaxis, such as the CCL20 and the CCL28. And they were also able to demonstrate that most of these proteins return to normal levels in convalescence. What we saw in the children's cohort was something similar to what has been noted in the published cohorts. We separated our cohorts into three different ones. The patients who were labeled as MIS-C confirmed satisfied the CDC definition of MIS-C and had either a positive SARS-CoV-2 antibody or PCR. The MIS-C probable cohort satisfied the clinical definition for MIS-C but had negative antibody and PCR. And the negative controls were initially worked up for MIS-C, but then subsequently were noted to have an alternate diagnosis. As you can see here, the blue circles representing the MIS-C patients separate out nicely compared to the MIS-C probable and the negative controls. We were further able to demonstrate an elevated level of IL-10, IL-6, and also soluble IL-2 receptor in our cohort. Not shown in the diagram here were subphenotype analysis that did not show a difference in the cytokine expression between patients who had a Kawasaki phenotype versus those who did not. We did notice that patients who were ICU bound and who had SARS-CoV-2 PCR positivity tended to have elevated levels of IL-6 and IL-10 compared to those who were not. We also noted that patients who had reduced cardiac function had elevated IL-6 levels. Soluble IL-2 and IL-2 levels were elevated in ICU patients, and TNF alpha was elevated in patients who were SARS-CoV-2 PCR positivity. We saw that IL-17 levels were higher in patients who did not have cardiac abnormalities. In summary, MIS-C elicits a distinct immune response from that of acute COVID-19 infection and Kawasaki disease. The sum of IL-10 and TNF alpha differentiates between MIS-C and severe COVID-19 infection. The cytokine storm seen in MIS-C is less robust than seen in macrophage activation syndrome due to other conditions such as systemic JIA. Cytokine profiling indicates myeloid cell chemotaxis and mucosal inflammation, and there is normalization of cytokine elevation during convalescence. Now we'll shift gears and talk about immunomodulation in MIS-C. The American College of Rheumatology came up with guidelines for management of MIS-C in the summer of 2020. This guideline has gone through 2 iterations. The highlight of the guideline regarding immunomodulation specifically is a stepwise progression. The guidelines recommend that all hospitalized patients receive IVIG 2 grams per kilo. A second dose of IVIG is generally not recommended. Glucocorticoids at a dose of 1 to 2 milligrams per kilo per day is recommended as an adjunctive treatment. And in patients who have suboptimal response to these steps, the next step is pulse dose steroids, which is 10 to 30 milligrams per kilo per day. High dose anakinra, defined as more than 4 milligrams per kilo per day, either IV or subcutaneously, is reserved for refractory MIS-C patients. They recommend immunomodulation to be weaned slowly over 2 to 3 weeks to prevent rebound phenomena. The UK guidelines that was developed by a Delphi consensus process slightly differs from the ACR guidelines in that they divide MIS-C patients into 2 phenotypes, Kawasaki and non-Kawasaki. The Kawasaki phenotype patients are treated with IVIG 2 grams per kilo. They do recommend a second dose of IVIG in those who have incomplete response. Methylprednisolone in pulse dose range, that is 10 to 30 milligrams per kilo for 3 days is recommended as a second-line agent, and infliximab is recommended as a third-line agent. For those with non-specific phenotype, meaning non-Kawasaki-like phenotype, the guideline for first line and second line remains the same. However, they leave the choice for the third line up to the treating physician. The Delphi survey respondents had equipoise between the choice between infliximab, anakinra, and tocilizumab. It is to be noted that this Delphi process informed the treatment groups for the UK recovery trial, which is the first randomized controlled trial looking at treatment for MIS-C globally. This study from France was able to retrospectively compare patient outcomes in those who were treated with a combination of IVIG and methylprednisolone with those who were treated with IVIG alone. They were able to demonstrate that patients who were treated with the combination of IVIG and methylprednisolone fared much better in terms of treatment failure when compared to those who were treated with IVIG alone. Along the same lines, several of the secondary outcomes, such as second-line treatment, hemodynamic support, left ventricular ejection fraction, and also duration of PICU stay, was favorable in the IVIG and methylprednisolone group. Several biologics are being used in MIS-C. Anakinra is considered a good choice due to experience in treatment of systemic GIA, macrophage activation syndrome, Kawasaki disease. Anakinra has also been used in sepsis trials and has also been used in adult COVID-19 infection. It has a short half-life that enables early treatment in sick patients, even when other infectious etiologies have not been completely ruled out. Elevated IL-6 have been consistently seen in COVID-19 and MIS-C, and IL-6 also has a role in refractory Kawasaki disease. However, IL-6 inhibitors should be used with caution because of their long duration of action. TNF-alpha is also elevated in COVID-19 and MIS-C, and infliximab also has a role in treatment of refractory Kawasaki. Along the same lines as tocilizumab, use of infliximab must also be carefully weighed because the duration of action is longer, and we need to make sure that other infectious etiologies have been ruled out. There is a potential role for JAK-STAT inhibition, as well as there have been more studies that have been looking into how the JAK-STAT pathway is involved with COVID-19. University of California at San Diego has recently launched a multi-center trial looking at comparative effectiveness between infliximab, anakinra, and methylprednisolone. This and the UK recovery trial will perhaps inform the optimal choice of biologics in this disease process. I'm showing you this chart to illustrate the timeline of MIS-C at our center in relation to when MIS-C was reported and the various studies published. The first case at Children's National was diagnosed on April 27th of 2020. Around the same time, the UK PQ alert came out. Within a matter of weeks, Children's National was able to put together a multidisciplinary MIS-C task force with representation from various subspecialties. And we were able to establish our treatment algorithm by the 20th of May, before the ACR guidelines came out. Having a standardized method for evaluation and management of MIS-C patients has served us well. To date, we have treated around 155 patients with MIS-C. We have had only one patient require ECMO. We've had one bounce back and no mortality. This is an overview of the immunomodulation algorithm that we use at Children's. Don't worry, I don't expect you to read the small font here. I'm going to go through the highlights of the immunomodulation pathway that we use here. We treat all our patients with IVIG 2 gram per kilo, regardless of their Kawasaki phenotype. And we use anakinra as a second-line agent at a dose of 6 to 10 milligram per kilo per day. The dose is generally given IV, divided Q6 hours. In the presence of renal injury, we renally dose the medication dose and give it twice daily. The maximum dose of anakinra that we use is 600 milligram per day. The weaning schedule is generally coming down by 2 milligram per kilo per day on every day or every other day basis based on the patient's clinical picture. As an institution, we decided to use anakinra as a second-line agent versus corticosteroids, partly due to our experience as a center with viral myocarditis. This decision was also informed by systematic meta-analysis and Cochrane review of viral myocarditis that did not support routine use of corticosteroids. Early on in the pandemic, we did not know how much of a cardiac burden this disease process would have. So we chose to opt for corticosteroids only as a third-line agent. We reserved the other biologics, such as tocilizumab, infliximab, or JAK inhibitors for refractory cases. In summary, I've described the ACR and UK guidelines that provide a framework for management of MIS-C. In most cases, IVIG is used as a first-line agent. Corticosteroids are recommended as adjunct therapy in both of these guidelines. Today, I've shared with you our experience using anakinra as a second-line agent. Option of using such a steroid-sparing agent is attractive, although cost and availability may preclude wide usage of this regimen. Other centers have preferentially used either tocilizumab or infliximab. We need comparative effectiveness trials, such as the ones that are starting to help inform which immunomodulation is ideal. We have a lot more to learn about this condition, and I would like to leave with some additional questions to ponder. Is there now time to refine the case definition for MIS-C? Are the hospitalized MIS-C patients only the tip of the iceberg? Do patients with MIS-C have an inherent defect in their innate immune system? Do all patients with MIS-C need IVIG? What is the appropriate dose and duration of corticosteroid treatment? What is the role of biologics? If so, which one is better? Will we continue to see MIS-C post-pandemic? And finally, now that the vaccination trials are ongoing for younger kids, is it safe for MIS-C patients to get COVID-19 vaccine? Hopefully, we'll get answers to these questions in the coming days. These are my references. I would like to acknowledge the MIS-C task force and also my colleagues in the Division of Rheumatology, without whom all this work would not have been possible. Thank you for your attention. I would be happy to take questions during the panel discussion.
Thank you so much, Dr. Srinivasalu. I have to say, I'm sorry I lost the connection and didn't have the honor of introducing her, but as you can see, we selected her because she's been an absolutely integral person on our multidisciplinary task force for this whole year. She's really been integral in coming up with the diagnostic and particularly the immunomodulatory regimens, and she sits on national groups so that we get both her local expertise as well as the national data. So really, thank you so much, Hema, for fabulous talk, and we'll certainly have questions for you, many of which you already posed to have us ponder between the next speaker and the session. So thank you.